Epstein-Barr Virus, EBV, and Infectious Mononucleosis, Unveiling the Silent Invader. Welcome to our deep dive into the fascinating world of the Epstein-Barr virus, or EBV, a microscopic entity with a profound impact on human health. Also known as human herpesvirus 4, EBV is a pervasive member of the herpesvirus family, distinguished by its double-stranded DNA structure. Though tiny in size, this virus is mighty in its reach, silently affecting populations across the globe. EBV is not just another virus, it's the primary culprit behind infectious mononucleosis, commonly referred to as mono, orthoglandular fever. Understanding EBV isn't just academic, it's essential for healthcare providers and patients alike. Recognizing its manifestations can make all the difference in diagnosis and management. Let's journey back to the 1800s, a time when infectious mononucleosis was first acknowledged as a distinct clinical syndrome. Characterized by fever, a sore throat, and swollen lymph nodes, it puzzled many. The term glandular fever was coined in Germany in 1889, capturing the essence of the swollen glands observed in patients. Fast forward to 1920, when Sprunt and Evans provided the first detailed clinical description in the Bulletin of the Johns Hopkins Hospital. They spoke of a mononuclear leukocytosis in reaction to acute infection, laying the groundwork for linking these symptoms to what we now know as EBV. But how does EBV weave its way into our bodies? Transmission primarily occurs through intimate contact with oropharyngeal secretions, think sharing utensils, drinks, or a kiss. Yet, it doesn't stop there. EBV can also spread via genital secretions, blood transfusions, and organ transplants. Once inside, the virus targets B cells within the oropharyngeal epithelium. EBV is cunning. It can linger in a latent state within these cells for weeks, years, or even decades, reactivating when conditions are favorable. Our immune system doesn't take this invasion lightly. Both humoral and cellular responses are activated. CD8 cytotoxic T cells and natural killer cells play pivotal roles in controlling the proliferation of infected B cells. However, if the T-cell response falters, it can lead to unchecked B-cell proliferation, increasing the risk of lymphoma development. Clinically, EBV is a master of disguise. While many infections fly under the radar without symptoms, when they do manifest, they present a characteristic triad: fever, pharyngitis, and lymphadenopathy, typically surfacing after a 4 to 6 week incubation period. Patients often report severe fatigue, malaise, a sore throat, and high fever. Physical findings evolve over time, from early signs like lymphadenopathy and pharyngitis to later development such as splenomegaly and hepatomegaly. Dermatological signs offer valuable clues in diagnosing EBV infections. Exanthem, maculopapular rash. Imagine developing a rash after taking antibiotics for a sore throat. Up to 80% of EBV-infected patients treated with ampicillin or amoxicillin experience this distinctive maculopapular rash. It's typically non-itchy, featuring small red or pink spots that may be slightly raised, spreading across the trunk and extremities. Thankfully, it usually fades within a few days to a week. Why does this happen? It's believed to be an immune response, a reaction between the medication and viral antigens present in the skin. Palatal petechiae. These are small, pinpoint red spots found on the soft palate. While not exclusive to EBV, their presence alongside symptoms like a sore throat and fever strengthens the case for infectious mononucleosis. They likely result from minor hemorrhages due to local inflammation and vascular injury in the oropharyngeal region. Periorbital edema, Hoagland sign. Early in the illness, some patients notice transient swelling of the eyelids, a sign known as Hoagland sign. This periorbital edema is relatively specific to EBV, infectious mononucleosis, and is thought to stem from localized inflammation and fluid accumulation triggered by the viral infection. Accurate diagnosis is key to effective management. Dermatological examination plays a crucial role. A visual inspection can quickly identify characteristic rashes and edema, prompting further investigation and helping differentiate EBV from other conditions. Patch testing. When a rash develops after antibiotic use, patch testing can help determine if it's a drug-induced rash or a true allergic reaction. This distinction is vital for future medication choices. Skin biopsy. Though rarely needed, a skin biopsy might be performed if the rash is atypical or the diagnosis is uncertain. Histopathological examination can rule out other conditions like drug hypersensitivity reactions, other viral exanthems, or even cutaneous lymphoma. Serological tests. The monospart test, or heterophile antibody test, offers a quick and effective diagnosis in adolescents and adults, though it's less reliable in children. For more specificity, EBV-specific antibody testing can be employed. Tests for viral capsid antigen, VCA, IgM and IgG, and EBV nuclear antigen, EBNA, provide a timeline of infection. VCA-IgM is typically positive during the acute phase, while EBNA appears in the convalescent phase and persists for life. When it comes to treatment, most EBV-associated rashes and skin manifestations resolve on their own. Supportive care is the mainstay, ensuring patients stay hydrated and get plenty of rest. Topical treatments. Topical corticosteroids may be used sparingly to alleviate inflammation and itching, but caution is advised to prevent skin thinning and other side effects. Emollients can soothe dry or mildly irritated skin. Systemic treatments. Corticosteroids like prednisone might be prescribed in severe cases, especially when significant edema or throat swelling poses a risk of airway obstruction. Doses range from 0.5 to 1 mg/kg day, typically for a short duration of a few days to a week. Antivirals such as aciclovir, 400 mg 5 times daily for 7 to 10 days, have been used in severe or complicated cases, particularly in immunocompromised patients. However, their effectiveness in uncomplicated EBV infection is limited. Avoidance of certain medications. A crucial point in management is medication awareness. Patients diagnosed with EBV should avoid antibiotics like amoxicillin or ampicillin, given the high incidence of rash development not due to an allergy but as an interaction with the virus. Preventing the spread of EBV involves simple yet effective measures. Educate patients about how the virus transmits, primarily through saliva. Advise them to avoid sharing drinks, utensils, or engaging in activities that could transmit the virus during the infectious period. Patient counseling is equally important. Reassure patients about the benign nature of the EBV-associated rash and the expected course of the disease. Emphasize that while the rash might be visually concerning, it typically resolves without intervention. In conclusion, a thorough understanding of the dermatological manifestations of EBV enriches our ability to diagnose infectious mononucleosis promptly and accurately. Effective management hinges on symptomatic treatment and empowering patients through education, mitigating discomfort, and alleviating unnecessary worries. As dermatologists and healthcare providers, we stand at the forefront of a multidisciplinary approach. By combining clinical acumen with compassionate care, we ensure optimal outcomes for our patients, guiding them through the silent invasion of EBV with confidence and expertise. Thank you for joining us in unraveling the story of the Epstein-Barr virus and its significant role in infectious mononucleosis. If you found this video informative, please like and subscribe to our channel for more insightful medical content. Your support helps us continue to provide valuable information to viewers like you. Stay informed, stay healthy, and we'll see you in the next video.